And Pulkeshi, you'll be there with us?
Yes, madam, I'll be with you.
Okay, so any more students joining, you can go on adding them.
Sure, madam.
All right. So, students, today's topic will be trophoblastic diseases, and we've been completing the complications related to the first trimester of the pregnancy. We have covered up with abortions and ectopic pregnancy, and today I'll be dealing with trophoblastic diseases. So, regarding this topic, the pattern what I'm following is today I'll cover up the theory or the theoretical part of it, highlighting the important points which you all need to understand and listen to. And then in the next subsequent classes, maybe one or two, we will solve the MCQs related to this topic. Okay. So as I begin, as I told, there are very few important theoretical points which I would like to highlight, starting with the definition. What do you mean by trophoblastic disease? So trophoblastic disease is any gestational trophoblastic disease. It encompasses a spectrum. You know, it's a common. It involves many other. Many of the diseases, not just one disease. It's a spectrum of proliferative abnormalities of trophoblasts, and it is most of the times associated with pregnancy. And persistent gestational trophoblastic disease, where there is a persistently raised beta HCG, is referred as a gestational trophoblastic neoplasia. So understand here, there are two aspects. One is the gestational trophoblastic disease, which is restricted to pregnancy or associated with pregnancy. And once you manage it, it is going to kind of end or subside after the pregnancy or once you kind of evacuate it. But persistent gestational trophoblastic disease or the gestational trophoblastic neoplasia is a condition where, in spite of you treating or evacuating, the most common being the molar pregnancy, and treating that particular disease, it again persist and kind of go to a neoplastic stage. So such condition or such diseases are called a gestational trophoblastic neoplasia. So remember, the gestational trophoblastic diseases will have the potential or they will grow into a neoplastic condition later. So that's why it is always very important for us to follow up any patient with a trophoblastic disease, to follow up so that the patient is not ending in a neoplastic stage or neoplastic state of the disease. So this is the definition per se, and you should understand these two entities, that is the gestational trophoblastic disease and the gestational trophoblastic neoplasia. Okay, clear, students? I hope you're all with me.
Yes, ma'am.
Okay, so accordingly they're classified. There are different types of classifications of these kind of trophoblastic diseases. The conventional classification involves it by terminology. They divide into hereditary-form mole, invasive mole, choriocarcinoma, or placental trophoblastic tumor. I'm sorry for the spelling mistake here. Next, there is a WHO classification. Again, it is classified into hereditary-form mole, which is of two types, complete and partial. And then you have the invasive mole, the placental site trophoblastic tumor, choriocarcinoma. And in that choriocarcinoma, it may be non-metastatic disease where it is confined just to the uterus, and the metastatic disease. So the choriocarcinoma is up till hereditary-form mole, you can consider it as a gestational trophoblastic disease. Once it moves into invasive mole or placental site trophoblastic tumor or choriocarcinoma, these three fall into the category of the gestational trophoblastic neoplasia, as we discussed previous slide. So choriocarcinoma is, as you can get through the name carcinoma, it's a neoplastic disease. So it may be non-metastatic or metastatic. So metastatic disease is usually again classified into two groups, that is low risk or having a good prognostic prognosis, and high risk where the prognosis is poor. Now, low risk is categorized into, or these features will categorize the patients to a low risk group, even though there is a metastatic disease. So the disease is present in less than 4 months duration. Initial serum beta HCG levels is less than 40,000 milli-internationals per ml. Metastasis is limited to lung and vagina only. There is no prior chemotherapy given and no preceding term delivery. So these are the criteria which would make a good prognosis such patients, and it is characterized as low risk metastatic disease. Now, the high risk or the poor prognosis criteria include long duration, more than 4 months, initial serum beta HCG levels more than 40,000 millijoules per ml, brain or liver metastasis, failure of prior chemotherapy, following term pregnancy, and WHO score of then 8. So these are the criteria for metastatic diseases with low risk and high risk. Now, coming to hydatidifform mole. This is a benign neoplasm, remember, of chorion potential. So, remember, and a lot of well, most of the times it does not harm. Potentially, so the idea for most form of gestational trophoblastic disease, it is partly generated, partly proliferate young chorionic villi. So this is a feature of the hydatidifform mole. Look, the hello. Hello.
Madam, sorry for the interruption, madam.
Yeah, there was some disconnection, I think.
Yes, madam. Your voice is not audible, madam.
Now is it audible?
Yes, clearly, madam.
Is it not audible?
It's audible, madam, now.
It's not?
It's audible, madam.
Okay, I think there was some disconnection in between. The net wasn't that great, I guess. Hello?
Yes, madam.
Okay, so just give me a moment. I'll move to a proper place so that the net is better there.
Okay, madam.
Yeah. So if the students are online, I'll just continue. So as I told, it is characterized by grape-like vesicles, and most of the time it is very, very typical, and anybody who has seen it would remember it definitely. And the vesicles are filled with interstitial fluid similar to ascitic or edema fluid, but it is very rich in the hormone HCG. Now, microscopically, it is characterized by marked proliferation of the syncytial and the cytotrophoblastic epithelium. There is thinning of the stromal tissue due to hydropic degeneration or edema of the villus stroma. The villi are avascular, and the maintenance of villus pattern is persistent. So these are the features you can note, or the pathological features, that is gross features and the microscopic features.
Madam, sorry for the interruption, madam.
Yes, yes.
Your screen is not shared, madam, please.
Okay. I think I need to do the settings again.
Yes.
Pulkesh, I'm unable to go to the screen where I have to share the, that.
There will be one option, madam, in middle of your screen. Share screen. One green color option will be there, madam.
No, I'm not getting that screen only now. How do I go back to that screen?
Madam, maybe it got minimized, madam. You just see the taskbar, madam.
Yeah, okay, fine, got it now.
Yes, madam.
Yeah, is it seen now?
Yes, madam.
Okay.
Yes, madam. Thank you, madam.
So yeah, thank you so much, and I'm sorry for all these technical problems. So I think we discussed about this metastatic disease, the low prognosis and high prognostic groups. So I was talking about the hereditary for mole, and as I said, it's a benign neoplasm of chorion with malignant potential, and it's most common form of gestational trophoblastic disease. It is an abnormal condition of the placenta where there are partly degenerative and partly proliferative changes in the young chorionic villi. So pathological features of the chorionic, hereditary form mole, you should always, if you once see, you will definitely remember these grape-like vesicles are seen, and the vesicles are filled with interstitial fluid similar to ascitic or the edema fluid, which is, but one important thing is it is rich in HCG because it is secreted by the chorionic villi. Now, microscopically, it is characterized by marked proliferation of the syncytial and cytotrophoblastic epithelium, thinning of the stromal tissue due to hydropic degeneration. The villi are avascular, and the maintenance of the villus pattern is maintained. So here is a picture. We can see small vesicles. They're like typical grape-like things, and the whole of the placenta, the tissue is like filled with these kind of grape-like vesicles. So this is one more picture again where you'll be able to see fluid-filled vesicles. So histologically, as I told, there will be edema of the villus, and there is slight difference between the microscopic picture of a complete mole and a partial mole. So the hereditary form mole is again divided into complete mole and partial mole. Complete mole is where there is no fetal tissue at all, and partial mole is where some part of fetal tissue is present and a part of the placenta is converted into a molar kind of a tissue. So microscopically, they can differentiate whether it was a complete mole or a partial mole after the HPV we give after the evacuation. So these are the pictures of the histological patterns. Then you have the incidence and risk factors. Now, incidence is maximum in Asia and South America and least in the US. Maximum incidence is seen in Philippines, 1 in 80. In India, it is 1 in 400 pregnancies. Risk is more in women where too elderly, like more than 35 years, or too younger, that is less than 18 years. Low socioeconomic status, history of molar pregnancy, diet deficient in protein, folic acid, and vitamin A, and group A women married to group O men. This has been one important factor, and these are considered as the risk factors for the molar pregnancy. Now, the maternal age more than 35 years and dietary deficiencies are risk factors for complete mole, whereas for the partial mole, it is linked to the use of oral contraceptive pills and history of irregular menstruation. So this is again a differentiating factor where they have found that the risk factors for complete mole are different with respect to the partial mole. Now, familial repetitive hereditary form mole has been linked to a missense mutation in NLRP7 locus or chromosome 19. So remember, there is a genetic mutation responsible for hereditary form mole, especially when it is seen in the familial pattern where a lot of the family members have been affected, and in that scenario, you need to evaluate and especially get a karyotype done to see if there is any presence of this particular mutation, and it is on chromosome 9. In one report, this mutation was present in 60% of the patients who had 2 molar pregnancies. So when the molar pregnancy is repetitive, or if it is seen in multiple members in the same family, then you need to suspect a genetic mutation. And if you evaluate, and as they have reported in one study, 60% were positive in such cases. Now, coming to differentiation between a partial mole and a complete mole, we will study few features which would tell us what is the difference between the two. Now, if you take up the karyotype in partial mole, it is usually triploid. That is, the chromosome number is 69, and the extra haploid set of chromosomes usually is derived from the father. So remember, normally the karyotype, the normal chromosomal number is diploid, is it not? We have 46XX or 46XY is the normal pattern of the chromosome numbers what we have. Whereas in partial mole, what happens is there is a triploid. So there is an extra set of haploid set of chromosome coming up, and most of the times it is from the derived from the father, where it usually results from fertilization of a normal egg by 2 sperms. So in that case, it results with 69 chromosomes, which could be XXY or XXX as well. So it will depend on what type of the sperms are fertilizing the ovum. It could be XY or XX. So this is the pattern of the karyotype, that is triploid in partial mole, whereas a complete mole is most of the times diploid. And the most common chromosomal pattern is 46XX in 90% of the cases, and 46XY in only 10% of the cases, or it could be 45XO. Okay, now the chromosomes are entirely of paternal origin, as an empty ova is fertilized by single sperm, or the chromosome set of sperm undergoes duplication. That is how all chromosomes are of paternal origin. This process is called as androgenesis. So there are two possibilities. How it comes to a diploid complete mole is where the empty ova, the ova is empty and then it is fertilized by a single sperm, or the chromosome set of the sperm undergoes duplication, and that therefore the chromosomes are all coming from the father or the paternal origin, and this process is called as androgenesis. Hope it is clear. Okay, I'll just subsequently explain in the next picture. In 80%, a single sperm fertilizes an empty ovum, that is monospermic, and in 20% fertilization is done by two sperms, that is dispermic. So if you can look at this picture here, there is a loss of maternal chromosomes before or after fertilization, and there is a duplication of the paternal chromosomes. So this leads to, though one sperm is fertilizing the ovum, there is subsequent loss of the maternal chromosomes due to some aberration. They just fall out or come out, and then the paternal chromosomes itself will duplicate and form 46XX, and that will result in a monospermic kind of complete hydatidiform mole. And the other pattern of the fertilization could be an empty ovum. Again, you can see the arrow showing here the chromosomal sets of the mother, somehow they are eliminated, and the empty egg is fertilized by two sperms, that is, it could be 23X or 23X or Y. So this results again in diploid number of chromosomes, that is 46XX or 46XY, but they are again originating from the totally from the father only, but from the two sperms. So it is a dispermic complete hydatidiform mole. Another type, or the diploid biparental, is where the normal ovum with the normal set of the haploid set of chromosomes is fertilized by 23X or Y, and because of some mutation, as we discussed in the chromosome 19, this results in diploid biparental congenital complete hydatidiform mole. So this is where a diploid biparental occurs in case of mutation in case of chromosome 19. Now another kind, that is in case of partial hydatidiform mole, what happens is it is again it is not dispermic, actually it is dispermic, but it is triploid. So two sperms do fertilize the egg or the ovum, and there is three sets of chromosomes, one from the mother and two from the father, and that results in 69XXY triploid set of it is triploid in karyotype, but remember it is dispermic. So is it clear to all of you what is the what do you call the genetic basis behind the complete hydatidiform mole and the partial hydatidiform mole? Is it clear to all of you students?
Yes, ma'am. Always extra genetic material is from ma'am father.
Yes, correct. Fine. So this is very important for you to understand, and I want you all to be very clear in this. I don't want you to have any doubts regarding this. If at all you have, please let me know now. I can explain it again. Everybody understood that?
Yes, ma'am.
Okay, so I'll just go ahead. So remember, once again, partial hydatidiform mole is triploid, and complete hydatidiform mole is diploid, and the diploid nature could be either monospermic or dispermic, or it could be diploid biparental. Okay. Next, what are the other features to show whether it is partial or complete mole? Pathology. On pathology, the partial mole, the trophoblastic proliferation is less marked, Some villi are present, some blood vessels are also present, and some fetal tissue is present. This is very important feature of partial mole, being the fetal tissue being present, but it is important to remember that it is incompatible with life. Okay, so it's not a viable fetus. Now, in complete mole, there is extensive trophoblastic proliferation. There is no villi formation, no blood vessels, and absolutely no fetal tissue. So these are the pathological features. On HPE, trophoblastic inclusion body is present. Scalloping of the chorionic villi is present, whereas both the features are absent on complete mole. Clinically, most common presenting feature is bleeding per vagina, followed by a period of amenorrhea, and there is passage of grape-like vesicles. This typical complaint or an observation by the patient is less in partial mole, because only a lesser amount of the vesicles are present, and most of the times the patient will not be able to pass them so as to really appreciate the passing of the grape-like vesicles. Whereas the clinical features in complete mole are same as in the partial mole, that is, there is PV bleeding followed by a period of amenorrhea, and again there could be observation and passage of the grape-like vesicles by the patient in the complete mole. So that possibility is more in a complete mole because it is completely filled, the whole of the uterus is filled, and if the patient is having a dilated cervix or an incompetent cervix, then passage of some blood clots along with the vesicles is appreciated and complained by some of the patients. Right, on examination, now the height of the uterus is equal to or less than the period of gestation in case of partial mole, whereas always remember that the height of the uterus is more than the period of gestation in complete mole. So this is one of the conditions where it's a very common question in the undergrad levels, where the teachers will ask you which are the conditions where the height of the uterus is more than the gestational age. So the most important point or the answer you have to remember is a complete mole, or other conditions where the height of the uterus is more than the period of gestation. You all have to enumerate. Anybody can tell me what are the other conditions where you see the height of the uterus more than the period of gestation? That means if the patient is giving you a history of 3 months amenorrhea, and if you palpate the uterus, if you feel that the uterus is like 20 weeks uterus, just for 3 months amenorrhea. So what are the conditions you can tell me? Anybody?
Ma'am, wrong date.
Wrong dates, yes, that is the most common one, where you will have to make sure that the dates are exact or the correct ones. Correct. Next.
Ma'am, when
Yeah.
the amniotic fluid is more.
Okay, so that is polyhydramnios. Correct. Next. Which is more common? Yes. Yes, students, this is a very basic question.
Multiple gestation.
Correct. Multiple gestation or the twin pregnancy or triplet pregnancy. Correct. Anything else? Any other condition you can think of?
Malpresentation.
Malpresentations usually will not cause, the alterations in the height of the uterus, unless it's a transverse lie where at term, because of the position of the baby, transverse lie, the height of the uterus can be slightly lesser than the, the normal gestation. So malpresentations most of the times do not cause any much alteration in the height of the uterus.
Okay.
Anything else that can come to your mind? Fibroids, okay, fibroid uterus. So whenever there are multiple fibroids or large fibroids in the uterus along with the pregnancy, then you will feel that the size of the uterus is more than the period of gestation. Okay, so these are some of the common conditions you should remember, right? So let's go to the next slide. Now, what are the complications which are seen in partial mole? There could be thyrotoxicosis, preeclampsia, hyperemesis gravidarum, preliminary embolic conditions leading to ARDS. Sorry, this is not preliminary, this is pulmonary. I'm sorry for the error here. It's pulmonary embolism leading to ARDS. So these are the complications which are seen in partial mole. But remember that the incidence of these complications is lesser in partial mole compared to complete mole. So all these complications are seen again in the complete mole, but to a far greater extent, and also very severe kind of complications to a very severe extent as well. So that these are the important ones you have to remember. The investigation of choice is ultrasonography in both the conditions. On ultrasonography in the partial mole, you most of the times get confused with a missed abortion, because you will be able to see some fetal tissue there, and there could be a gestational sac, a fetal pole, and still there could be presence of molar tissue in the placental area. So most of the times, if you miss the presence of these what you call the vesicular tissue within a part of the placenta, then you might confuse it with a missed abortion, where the fetus is there but the cardiac activity is absent. So that's how the picture will be in partial mole. Whereas in complete mole, there is absolutely no fetal tissue, as we mentioned, and the whole of the uterus is filled with a typical snowstorm appearance, is what is called for the in case of the complete mole. So the gold standard for diagnosis is histopathological examination for both the cases. And as we discussed in the previous slide, I showed you a histological picture, and they can identify whether it is a partial mole or a complete mole. And confirmation is always by the histopathological examination. So again, the other features, HCG levels are raised in partial mole, but not markedly raised, whereas in complete mole, it is raised for more than, this is 1 lakh actually. This is 1 lakh, more than 1 lakh milli-internationals per ml. Thecal lutein cysts are not seen in the ovary in case of partial mole, whereas there are bilateral thecal lutein cysts are present in the ovary in complete mole in most of the cases. Persistent gestational trophoblastic disease or neoplasia, as we discussed, this is a subsequent complication or a subsequent development in case of the molar pregnancies. The chance is only 3 to 5% in partial mole, whereas it is 15 to 20% in complete mole. So it is always very important to counsel the patient about this important complication, and that's why it is very important to put into her mind as to the follow-up. Why is follow-up of the post-molar evacuation so important? Is to detect whether the patient is going into a trophoblastic neoplasia. So the chances are 3 to 5% in partial mole and 15 to 20% in complete mole. And choriocarcinoma risk is less than or equal to 1%, whereas it is 4% in case of complete mole. So these are the features you should remember with respect to partial and the complete mole, and you should be able to differentiate the both with respect to the clinical features, the pathology, as well as the investigations. Another thing what you have to remember is, yes,
investigation of choice, is it ultrasonogram or transvaginal sonography?
anything is fine. Anything is fine. It's just ultrasonography. See, transvaginal sonography, it'll help only if you're unable to appreciate it on the abdominal. But what happens most of the times in complete mole or even partial mole is that, especially in complete mole, is that the even though the period of amenorrhea is just 2 months or 1.5 months to 2 months, the uterus will be blown up almost 3 times the size. It will be like 16 to 20 weeks uterus. So you can easily appreciate on ultrasonography this snowstorm appearance on the abdomen itself. You need not go for transvaginal sonography for diagnosis of the molar pregnancy, until, yes, in sometimes if you're confused, like in partial mole, and there is a part of the fetus, the fetal tissue is still there, you can see the fetal pole, and you can not appreciate the cardiac activity, of course, and there is a confusion, and on abdominal scan you cannot appreciate that typical the snowstorm or the chorionic villi within the placental tissue. Then you can go for a transvaginal sonography if necessary, and that will make it more clearer if at all you want to appreciate the molar tissue. And transvaginal sonography, remember, it will help only if the height of the uterus or the size of the uterus is smaller, maybe 10 to 12 week size. But beyond that, transvaginal sonography also is not very great to appreciate a larger uterus. You will not be able to kind of appreciate the whole thing on transvaginal sonography. Okay,
Yes,
so
ma'am.
it is mainly abdominal ultrasonography. As I said, only in case of early pregnancy, maybe 1.5 to 2 months. In case of partial mole, where you're confused whether it is missed abortion and you're suspecting some vesicular tissue within the placenta, you can go ahead with the TVS examination also.
Okay, ma'am.
But otherwise, it's abdominal.
Yes, ma'am.
Yeah, this I forgot to insert the picture of the snowstorm appearance. So maybe I'll just show you after the class. Now, another important thing you have to remember is how you suspect that the patient is having a molar pregnancy is the incidence of preeclampsia. Remember the preeclampsia as the definition. Preeclampsia is any hypertension along with proteinuria, and the definition, it is more than after 20 weeks of gestation, is it not? Now,
Yes,
most
ma'am.
of the times the preeclampsia will occur after 28 weeks, 32 weeks, 34 weeks, and even 36 weeks, people might develop preeclampsia. But when a patient develops preeclampsia pretty early, like maybe 22 to 24 weeks, that is a time when you need to suspect that there could be possibility of molar pregnancy if you have missed it earlier. Now, nowadays, it is very rare to miss the molar pregnancy until, the patient goes into a stage where she can develop preeclampsia before 24 weeks, because nowadays, most of the patients will get the ultrasonography within 3 months at least once, and you are definitely not going to miss out a molar pregnancy. So this is just a theoretical thing, but sometimes there could be such incidences, especially if the patient has been negligent and she's staying in a remote area where she's not accessible to the routine antenatal care. She's not gotten the ultrasonography at all, and suddenly she comes just with 3 to 5 months 5 months of pregnancy with she comes to you with eclampsia directly. She comes with convulsions. So in that case, if she's just less than as we said 24 weeks, and she comes with preeclampsia or eclampsia, you should always rule out the presence of molar pregnancy in such cases. Okay, and another important feature in case of molar pregnancy, on palpation, the typical doughy consistency has been described in the books, and that makes that this kind of feeling will come to you with experience only. So once you have experienced palpating so many normal pregnancies, then you will be able to identify, what is doughy consistency. Okay, so but theoretically, you should remember how the uterus feels in case of molar pregnancy. It is a doughy kind of a consistency. Okay. Now, how do you manage molar pregnancy? We do not wait for spontaneous expulsion nowadays because it carries a lot of risks of bleeding, patient going into shock, and so many other problems and complications. As we discussed, she might go into thyrotoxicosis, storm, pulmonary embolism, and so and so forth. So the treatment of choice in hereditary form mole, once we diagnose, is suction evacuation. And I wouldn't agree with the curettage here. It's just a suction evacuation, and it is the treatment of choice irrespective of the uterine size. So you can see the uterine size going up to sometimes 24 weeks, 28 weeks if the patient is negligent. But whatever said and done, the mainstay of the treatment for molar pregnancy is just the suction evacuation. So remember here, the suction evacuation, when it is done, it may not be completely like successful, or you may not be able to completely evacuate it in one sitting only. You will need 2 or sometimes 3 to 4 sittings also for some of the patients where there are a lot, where the size of the uterus is too large. So in such cases, what we do is we evacuate it try to evacuate it as much as possible, and to the extent that even if some amount of the tissue is left behind, we don't mind it, but we take utmost care that there is no perforation of the uterus in during the procedure. So that is the most dreaded complication which you would think of, that is perforation of the uterus, because the uterus here in molar pregnancy is very, very soft. Okay, if you just touch it, it's going to kind of what do you call it, there will be indentation on the uterus. So it's very, very soft, and there is very high chances, especially in the hands of inexperienced people or very freshers who are not used to, there are very high chances of perforating the uterus. So that's why we always underdo the suction evacuation in case of molar pregnancy. And once we evacuate say about 90% of the tissue, we can still afford to leave about 10 to 15% of the tissue behind, so that once the patient stabilizes, once the height of the uterus comes down, once the uterus contracts and the wall of the uterus is quite firm enough, we leave it, and then we recall the patient again after about 2 weeks time, and under the ultrasound guidance also we can repeat the suction evacuation. As I said, we do it second or even 3 times sometimes, but one important thing is to avoid any sort of complication, especially perforation, when you're doing such procedure. Okay. So as I said, once the myometrium has contracted, thorough but gentle curettage with sharp curettage, this is no more done nowadays. We don't do this. As I said, it's only suction evacuation, and even intraoperative ultrasonographic examination will definitely help. We do it in the operation theater itself. We keep the ultrasound by the side, and under ultrasonographic guidance we negotiate the uterus and try to locate where the maximum tissue is, and with the soft malleable latex cannula what we use for suction evacuation, with the same thing we try to gently curate as well as suction out the products. So this is how we do it practically. Now, hysterectomy is indicated only in case if the female has completed a family, irrespective of the age, and this is not really an indication to go ahead with hysterectomy. We can still follow up the patients. Uncontrolled hemorrhage during suction evacuation. So this is again a dreaded complication, as I said, and if the uterus does not contract and if the patient is torrentially bleeding, that is the condition where to save her life you might have to go ahead with a hysterectomy. Or as I said, if there is another complication like perforation, and there has been severe damage to the uterus and even adjacent structures, then immediately you have to open up, do the laparotomy and do a hysterectomy along with repair of any other adjacent structures being injured. So hysterectomy is only reserved for such emergency conditions. Now hysterotomy is where you just open the uterus like cesarean section, evacuate the products and then close it back. So this particular procedure is again indicated only in cases of complications like hemorrhage, where you're unable to go ahead with suction evacuation. You have to go as a last resort for hysterotomy, where you open the uterus, remove the contents and close it off like a cesarean section. So these are the management options for hereditary-form mole. Now, I cannot emphasize more on the importance of the follow-up of the molar pregnancy. As I told, it is always there is a possibility of the gestational trophoblastic disease or the hereditary-form mole getting converted into a neoplasm and also choriocarcinoma. So that's why it is important for follow-up. Now, how do you follow up these patients is, as I told, we do ultrasound and see that all the products of the conception are evacuated. If there are still any retained products of conception, then we do repeat suction evacuation. And once we are thorough, or we are sure that there are no more products of conception left within the uterine cavity, we discharge the patient and follow her up with the serial beta HCGs. So Up till 6 months is the ideal time you need to follow up such patients. And even though you have done hysterectomy for these patients for some reason, as we discussed earlier, does not mean that you need not follow her up. It is still important that you need to follow her up, because there could be a possibility of already the disease converting into neoplasia, and she might have metastasis somewhere already at the time of evacuation as well. So that's why, even though you have done a hysterectomy, removed all the the products of conception or the moles, it is still important to follow up such patients as well. So how do you follow up? As I said, with a beta HCG. So first beta HCG level is of course done pre-operatively for diagnosis, and then immediately 48 hours after the evacuation we get the baseline beta HCG for follow-up, and then the beta HCG is done every week until they become normal for 3 consecutive weeks. Okay, and once the HCG level falls to a normal level for 3 weeks, then the patient is tested for 6 months. Then the follow-up is discontinued and the pregnancy is allowed. During this 6-month surveillance period, the patient is advised not to become pregnant, and they have to use some contraceptive to prevent pregnancy, because otherwise what happens is, once there is a pregnancy in a patient who is following up post molar pregnancy, and what happens if there is a pregnancy is the beta HCG starts rising, is it not? Normally during any normal pregnancy the beta HCG starts rising. So now there is a confusion whether this rise in the beta HCG is because of the normal pregnancy or it is because of the persistent gestational trophoblastic neoplasia. So that's why once the beta HCG levels have come back to normal up till 6 months, and it is confirmed that there is no more rise in the beta HCG level, only then you advise the patient to become pregnant. So until then she has to use some method of contraception. Now the median time of resolution of partial mole is 7 weeks, and for complete mole it is 9 weeks. So this is about the follow-up of molar pregnancy. Now, other aspect of molar pregnancy is sometimes there might be a possibility of giving a prophylactic chemotherapy. Now, routine prophylactic chemotherapy is not advocated nowadays, and after evacuation of molar pregnancy, contraceptive advice is important, as we discussed. And remember, estrogen progesterone contraceptives or depot medroxyprogesterone is usually used to prevent a subsequent pregnancy during the period of surveillance. So these are the 2 preferred methods of contraceptive methods. Of course, the barriers like condoms are the best ones, but if not, we can still use oral contraceptive pills and even injections. Copper T is not used. That is what is important, you have to remember. So contraceptive of choice is combined OC pills. Earlier it was not advisable, but now they have shown that there is no risk with the OC pills, and that's why they can be used for contraceptive advice. The patient was advised not to be pregnant earlier for at least 1 year. Okay, but now, as we discussed, it is just the 6 months following a negative HCG. Now, some points about theca lutein cyst. Theca lutein cysts are seen in hydrotidiform mole, which is because of the high circulating levels of the hormone HCG, and it is seen in about 25 to 60% of the cases of complete mole. They vary in size from microscopic to 10 centimeters. They are yellow in colored. They are the result of overstimulation of lutein cysts by large amount of HCG, and they're also seen in cases of another important differential diagnosis for theca lutein cysts. Apart from molar pregnancy, you should remember they are seen in fetal hydrops, placental hypertrophy, or even multifetal pregnancy. So remember, the pathophysiology here for the formation of the theca lutein cysts is that the HCG levels are higher. So what are the conditions where the HCG level could be higher? One is molar pregnancy, and the other 3 conditions are these. That is fetal hydrops, placental hypertrophy, and multifetal pregnancy. Okay. Is it clear to all of you? I hope you're all following.
Yes, ma'am.
Okay. So proceeding further, theca lutein cysts regress spontaneously after suction evacuation, and they do not need any specific management. This is very, very important you should all remember. They are very large, sometimes even extending up to 10 to 12 centimeters on both the sides. But you need not do really anything to them unless they undergo torsion or hemorrhage or infarction, only in that case we need to intervene and maybe go ahead with an oophorectomy. Otherwise, most of the times, once the section evacuation is done, once the moles are all evacuated properly, the HCG levels drastically come down and these thecal utensils slowly regress on their own. Now, patients with thecal utensils of more than 6 centimeters have a very high risk of developing choriocarcinoma. So this is again a prognostic indicator where if the size of the thecal utensils is more than 6 centimeter, the possibility of choriocarcinoma is higher, and therefore you need to carefully monitor such patients. Now, this is all about the hydatidiform mole and the molar pregnancy. So we discussed about the types, that is partial, complete, the management, and the clinical features. So hope you all have understood.
Yes, ma'am.
Right. Shall we proceed for the next kind of the trophoblastic diseases, that is neoplasia or the neoplastic types?
Yes, ma'am.
Okay, so coming to these, now gestational trophoblastic neoplasia include invasive mole, choriocarcinoma, placental site trophoblastic tumor, and there is another one, epithelial trophoblastic tumor. So almost always these trophoblastic neoplasia follows some form of pregnancy. Either it could be a molar pregnancy, of course the incidence is higher following a molar pregnancy, but even following a normal pregnancy also there could be formation or development of these neoplastic diseases. So amongst all the cases of choriocarcinoma, remember these points: 50% develop following a hydatidiform mole, 25% develop following an abortion, 20% develop following a full-term pregnancy, and 5% develop following an ectopic pregnancy. So this figure is very important. You just have to remember this following in the following order: 50%, 25%, 20%, and 5%. Choriocarcinoma most commonly develops after molar pregnancy. High-risk choriocarcinoma develops after a full-term pregnancy. Complete mole has 15 to 20% chances of developing gestational trophoblastic neoplasia, and a partial mole has 3 to 5% chances of developing gestational trophoblastic neoplasia. So this we discussed already. There are a lot of questions, the MCQs coming up on these points. So I want you all to remember these properly. Okay. Next, what are the risk factors? Age of the female of more than 40 years, beta HCG levels of more than 1 lakh milli-internationals per ml, uterine size larger than the gestational age, bilateral thecal utensils of more than 6 centimeters, and if there is a slow decline in the beta HCG levels, that means if normally when we follow up the patients of molar pregnancy and when we follow up with the beta HCG levels every week, how the trend of the beta HCG falling, what is the falling trend of the beta HCG is they should be decline by 1 log. They say it should decline by 1 log. That means if the post evacuation, if the beta HCG level is say about 1 lakh. Okay, I'm just trying to write it with the mouse here. So if it is 1 lakh post evacuation, so how the trend of the beta HCG should be is that it should decrease by 1 log. That means it should decrease by 1 0. So after a week, if you do it, it should be 10,000. Okay, and then subsequently again, if you repeat it after a week, how much it should be? If it has to decrease by 1 log, it should come down to 1 0 lesser, so it should come to 1,000. Right? So again, the same thing. The next week, it should come down to about 100 or so. So this is how the trend of the falling of the beta HCG normally should be there when there is a complete evacuation of the molar pregnancy and it is not developing into a gestational trophoblastic neoplasia. So if there is any alteration in this falling trend, that means there is a slow decline of the beta HCG levels when you're following up, you have to suspect that the patient might have a postmolar gestational trophoblastic neoplasia. So this is how you can kind of suspect and evaluate the patient more thoroughly. Okay. Criteria for diagnosis of gestational trophoblastic neoplasia: when 4 consecutive HCG levels are plateau, as I said, normally it should fall by 1 log. If it is a plateau in the sense it comes in the same range of the values. If it remains at 10,000 and 1 week later it comes like 9,000 to 8,000, and subsequent weeks it is just remaining in those numbers like 9,000, 8,000, 10,000, it plateaus on subsequent weeks, then we can suspect that the patient might have a neoplasia. So that's what is important. And if the 3 consecutive HCG values are rising, so either the trend is a plateau, as in the first point, that means if you take a graph, if there is a plateau like this, if it is just like hanging around one value like say 10,000 units, or if there is a rise in the trend, or if there is a rise in the trend, especially 3 consecutive rises in the trend, then you have to suspect the neoplasia. So normally, as we discussed, the trend should be like this. It is following down by 1 log each. So if there is a plateau or if there is a rising trend, then you have to suspect the neoplasia. So the beta HCG level remain above normal even after 6 months of evacuation, or the histological criteria for choriocarcinoma. So once you have evacuated, according to the protocol, you have to send all the tissue for the HPE, and it has to be confirmed that it is just a simple molar pregnancy, either a complete mole or a partial mole. But if the HP itself is showing choriocarcinoma immediately after evacuation, then of course it's one of the important criteria for diagnosis. So remember these points as criteria for gestational trophoblastic disease. One is there is a plateau of beta HCG. Second is a rising trend of beta HCG, or if the beta HCG is still higher side after 6 months of evacuation, or there is a histological documentation of choriocarcinoma. So these are 4 important criteria for diagnosis. Clear to all of you?
Yes, ma'am.
Okay. So what are the clinical features? Now, the patients present with continuous bleeding PV even after evacuation. There is uterus, subinvolution of the uterus. The height of the uterus is still, palpable per abdomen in spite of evacuation. Invasive mole can lead to myometrial perforation and intraperitoneal hemorrhage. Persistence of thecal lutein cysts. Metastasis also could be one of the forms of presentation. Directly, the patient might come to you with a presentation where there is a metastasis in the lungs. She can come to
Cannonball.
hemoptysis or distress or even other features. So this is how the patient might come back to you with a gestational neoplasia. So remember a few points about choriocarcinoma. Most malignant tumor of the uterus. Its most common mode of spread is hematogenous, and most common sites of metastasis in choriocarcinoma are lungs in 80%, vagina in about 30%, pelvis in 20%, liver in 10%, and brain in 10%. And symptoms mostly present as irregular bleeding or uterine hemorrhage following an abortion, a molar pregnancy, or a normal delivery. Metastasis, lung metastasis, it is seen in 80% cases. Patient presents with respiratory symptoms like dyspnea, hemoptysis, chest pain, etc. On X-ray, it may produce the following 4 patterns. An alveolar snowstorm pattern. Remember, there are 2 places where you can, see a snowstorm pattern in case of gestational trophoblastic diseases. So one snowstorm pattern was in a complete molar pregnancy on ultrasonography, right? Now another one is in the X-ray of a metastatic lesion of a gestational trophoblastic neoplasia. So this you should be able to remember. Now discrete rounded densities or cannonball appearance, again showing the features of metastasis on the X-ray. Pleural effusion or an embolic pattern caused by pulmonary arterial occlusion. So these are the features of lung metastasis in case of the gestational trophoblastic neoplasia. Now this last point I would just discuss to the present relevant situation. You all have seen, I hope you all have seen a lot of COVID positive cases. Have you all read about it at least, even if you have not been able to manage them because all your colleges are closed now? But have you all read about the pathology in the case of the COVID positive cases? What happens in the lungs? Yes, anybody? What is the main pathology? What is that is affecting the lungs in case of the COVID positive patients? Anybody?
ARDS, ma'am.
Sorry?
ARTS?
ARDS is the last feature actually, but you remember in what is happening in the corona disease or the COVID positive patients is there is intravascular thrombosis occurring, and that is what is affecting the lung most in rather than a typical pneumonic patch, which is seen in cases of other viral pneumonias or bacterial pneumonia. What is happening in COVID positive cases is that it is affecting the intravascular, thrombotic phenomena is kind of accelerated, and there is a high rise in the D dimer. The pulmonary arterial occlusions occur, and that results in a lot of bronchopneumonia kind of a picture on the X-ray, and more prominently seen on CT scans. So the typical CT scan picture of a COVID positive affected patient, anybody can tell me what is it depicted as? How do you diagnose, or what is the typical diagnostic feature in case of CT scan of COVID positive patients? Yes? Anybody? It is seen as ground glass pattern. There is
Yes,
a
ma'am.
widespread pulmonary arterial occlusion and thrombotic phenomena occurring in the lungs, and it will appear as patches, especially affecting the lower lobes of the lungs. And of course the other part of the lungs is also involved, depending on how severe the disease is and how later the patient is coming. So it is called as typical ground glass appearance on the CT scan. Okay, so that you can correlate that this particular picture, if there is an embolic phenomenon occurring because of the metastasis in case of gestational trophoblastic neoplasia, then it will affect the pulmonary arterial system and result in such type of lesions on the CT scan. Okay.
Yes, ma'am.
Next, the vaginal metastasis occurs in 30% of the cases. It is usually suburethral or in the fornices, and it appears as purple hemorrhagic projection, and it is highly vascular and bleeds on touch. So, which is a very pathognomonic of choriocarcinoma, and we will be able to appreciate it on a per speculum examination. Sometimes when the patient is coming to you with complaints of persistent vaginal bleeding, and when you do a pelvic examination, when there is a vaginal metastasis of choriocarcinoma, you will be able to see and appreciate such a picture. Remember, purple hemorrhagic projections. Okay. So what are the important tumor markers for diagnosis diagnosis as well as for the prognosis of the neoplastic diseases? One is beta HCG and the other one is human placental lactogen. So these two are important tumor markers. So the FIGO staging for the gestational trophoblastic neoplasia or the trophoblastic lesions is into stage 1, 2, 3, and 4. Stage 1 is when the lesion is confined to the uterus. Stage 2 is when the lesion spreads outside the uterus but within the pelvis. Stage 3 is the lesion metastasizes to lungs. Remember, here, the most common site of metastasis is lungs. And even though there is a far end metastasis to lungs, it is still considered as stage 3. Okay. So when the metastasis is occurs to brain, liver, or even other GIT, then it is considered as stage 4. So this is the FIGO staging for GTT. So it's clear to all of you?
Yes, ma'am.
Okay, remember, within the uterus, outside the uterus, but only pelvis, lungs, and other tissues. Okay, or other organs rather. Next, there is a prognostic scoring system which has been developed by the WHO, and for each and every patient it is important to do this scoring system so that you can prognosticate as to how this patient is going to fare in terms of the treatment, the chemotherapy, and subsequent what do you call the survival, the 5-year survival in such cases. So what are the important points they have enumerated, and the scoring system is given as 0, 1, 2, and 3 points depending on these features. So this is again a table, and I want you all to see it properly and remember all these points. Now, what are the factors considered is age, less than 40 is 0, more than 40 is considered 1. Antecedent pregnancy, that means before the gestational neoplasm occurring, what has been the event in the obstetric history of the patient, what type of pregnancy she has had previously. So if it's a mole, then it is 0. If it is abortion, and if it's term pregnancy, it is 2 points. Then the interval in months from index pregnancy and chemotherapy started within the duration. This duration is also important. That means once the patient has been diagnosed following a pregnancy or a molar pregnancy, and within how many months is the chemotherapy started is also a matter of importance for prognosis. So if the treatment has been started less than 4 months, it is 0. 4 to 6 months is 1. 7 to 12 months is 2, and more than 12 months is 3. Then pre-treatment beta HCG level is important. If it is less than 10 to the power of 3, this is 10 to the power of 3, that means 10 into 10 into 10, that is 10,000. If it is less than 10,000, it is 0. If it is 3 to 4, that is power of 3, this is power of, I couldn't type the power on the scale, so that's why I just wrote it like that. So it is 10 to, if it is less than 10 to the power of 3, more than 10 to the power of 3 to 4, more than 10 to the power of 4 to 5, and more than 10 to the power of 5. So this scoring goes from 0, 1, 2, and 3 accordingly. Now, ABO group could be female and male. O or A and A or AB is considered as 1 and 2. The largest tumor, if the size, if you consider, if it is less than 3 centimeters, it could be anywhere. The tumor, in the sense, it could be anywhere. As we discussed, it could be just in the uterus, in the pelvis, or even the lung metastatic lesion. If it is less than 3, it is 0. 3 to 4 is 1, and more than 5 is 2. And the site of the metastasis, if it is lungs, it is a good prognosis where it's just the score of 0. Spleen and kidney is 1. Other gastrointestinal structures, it is 2. And brain and liver is poor prognosis, that is 3. So these are the features. Now the total score, how do you analyze this scoring? Is the patients having a score of 6 or less are considered as having low risk or a good prognosis, and a patient having a score of 7 or more are considered as having a high risk or a this is poor prognosis. Okay, there is an error here, so pardon me for that. It's a poor prognosis. So remember, 6 or less is good prognosis, 7 or more is poor prognosis. In general, a patient belonging to good prognosis or low risk group of 0 to 6 means that they can be treated by single agent chemotherapy. So it will not only help us to decide on the prognosis, but it will also help us to decide on the management as well, whether the patient needs a single chemotherapy or a multi-drug chemotherapy. So in a low risk group, we give just the single agent chemotherapy, which is usually successful. And in patient belonging to poor prognosis or the high risk group with more than score 7, they respond badly to chemotherapy and they require a prolonged hospitalization with multiple courses of chemotherapy. So this is how it is important for deciding on the management and prognostication as well. So is it clear to all of you?
Yes, ma'am.
Yeah, I hope you understood the scoring system and how do you interpret that. Okay. So coming to the management, chemotherapy is the treatment of choice for carcinoma. Methotrexate is the drug of choice, and when you are using a single drug regimen, the methotrexate is the drug of choice. And as I said, in low risk patients, in patients who have jaundice, where methotrexate is contraindicated, then we can use actinomycin D. Okay. So in case of single drug regimen, in low risk cases, the regimen is methotrexate, which is given as 1 to 1.5 milligram per kg body weight. It is given as either IM or IV on days 1, 3, 5. And then the folinic acid is given on day 7. Folinic acid is given in this dose on days 2, 4, 6, and 8. So you alternate it with the methotrexate and folinic acid. The course is to be repeated at intervals of 7 days till the HCG levels return to normal, followed by 3 more cycles of chemotherapy after the value normalizes. So this is a single drug regimen. In high risk group, that is if the score is 7, where you have to use a multi-drug chemotherapy, the most common regimen used is the Boxshaw regimen, where you use these drugs. It is also called as the IMACO regimen. Remember, EMACO, IMACO regimen, where E stands for etoposide, M for methotrexate, A for actinomycin D, C for cyclophosphamide, and O for vincristine. So this is used in high-risk patients or poor prognostic patients. Radiation also has to be used in some cases, especially when there are distant metastasis in the brain. And intrathecal high-dose methotrexate is also a form used to prevent hemorrhage and for tumor shrinkage. It has been used. In liver metastasis, with the help of interventional radiology, we can go ahead with hepatic artery ligation or embolization, or the whole liver radiation can be used sometimes. So hepatic metastasis has a poor prognosis. That is one thing you have to remember. So the modes of treatment in this kind of neoplasia is mainly chemotherapy. And if there is a distant metastasis, you might have to go ahead with other forms of treatment, that is radiation, intrathecal chemotherapy, and interventional radiology also helps in some cases. Now, coming to prognosis, the cure rate is almost 100%. It is very, very important to convince and counsel the patient properly that, you know, there is a 100% cure rate. In fact, the patient can get completely cured, and she can even plan for future pregnancies, especially in low risk groups. And about 70% of the cases in high risk group also have a very high cure rate. That is 70% will have a cure rate. Now, follow-up is mandatory for all patients. In low-risk patients, period of surveillance is 12 months, and is high in the high-risk group, it's 24 months. And until you are, the patient is in a period of surveillance, that is, she's following up, you have to ask her again to avoid pregnancy, as we discussed earlier. And later on, once we are sure after a period of surveillance, as mentioned here, she can always again go ahead and plan the pregnancy. Serum beta HCG level is measured weekly until it is negative for 3 consecutive weeks, and thereafter it is measured monthly for 6 months and then 6th monthly. Recurrences for non-metastatic, it is just 2 to 3%. Good prognostic metastatic disease, it is just 3 to 5%, and in poor prognosis disease, it is about 21%. So recurrence following 12 months of normal HCG level is less than 1%. So these are again theoretical values you need to remember if there are any questions based on this. So it's clear to all of you. Hope you understood all these points well.
Yes, ma'am.
Right. Coming to the last type of the tumor, that is it is also a very rare one as well, placental site trophoblastic tumor. This arises from the intermediate trophoblasts. Okay, and what you have to remember is mainly it is composed of cytotrophoblastic cells. So the intermediate trophoblast will give rise to this tumor, and it is mainly from the cytotrophoblastic cells. Now, these tumors have been associated with modestly elevated serum beta HCG levels. So the levels are not as high as seen in choriocarcinoma or even the molar pregnancy. So there has been only modest elevated levels of beta HCG levels, and they also produce variant forms of beta HCG. So that is another important point to remember. Now, in these tumors, identification of a high proportion of free beta HCG, that is more than 30%, is considered as diagnostic. Since there are a lot of variants of beta HCGs secreted by this kind of tumor, what is the important diagnostic criteria you have to remember for placental site trophoblastic tumor is that the free beta HCG should be more than 30%. Okay. And the HPL, that is human placental lactogen, is also a tumor marker for these tumors. Patient presence with vaginal bleeding, local invasion into myometrium and lymphatics occur. It is not responsive to chemotherapy, is another important thing you have to remember, and holds a very poor prognosis. And therefore, hysterectomy is the preferred treatment in such a scenario or in case of PSHTT. Clear to all of you?
Yes, ma'am.
Fine. So as I said, we just have come to end of the theoretical portion for the gestational trophoblastic disease. And it's almost time up now. If anybody has any doubts or any clarifications, about this presentation and the points, please ask, so that in the next class I can go ahead with the MCQs for the same topic. And I want you to revise this once before you come to the next class, so that it will all be easy for you people to understand, and you'll all be like promptly and easily answering the questions. Is it clear to all of you?
Yes, ma'am.
Yes, ma'am.
Okay, fine. I would just like to show the picture of the snowstorm appearance. Actually, I had saved it and somehow I couldn't. Are you seeing the screen?
Yes, ma'am.
Yeah, so this is how it looks. The picture of snowstorm appearance. This whole thing is the uterus actually. Okay, and then you can see the small vesicles here.
Ma'am, PPT is seen, sir, ma'am.
Oh, PPT
No.
is only seen. Yeah, 1 second. I'll just change the screen sharing. Yeah, can you all see now?
Yes, madam.
Yeah.
Yes, ma'am.
So this is the ultrasound picture of a typical snowstorm appearance of the complete mole. Here you can see the uterus. Okay. You can see the uterus here. This whole thing is the uterus, and the whole of the uterus is filled with some full tissue. And you can see the small vesicles here in some portion. And this typical thing is called as a snowstorm pattern. Okay. And there is no evidence of any fetal tissue here. Remember, there is no gestational sac, there is no fetal pole, there is no cardiac activity, nothing. So this looks like a complete mole, complete hydatiform mole. Okay, is it clear to all of you?
Yes, ma'am.
Fine. So yeah, anything else, students? Anything you want to ask? Yes, anybody?
No doubts, ma'am.
Okay,
Thank you, ma'am.
fine. Yeah. So thank you all so much. Have a good evening, and I'll see you next week with the MCQs of this part. And I want you all to really participate and answer them all quickly and easily. Okay?
Okay, ma'am.
Fine. Thank you all.
Thank
Thanks.
you so much, madam. Thank you
Thank
all.
you.
Thank you, Pulkesh. You can probably call off the meeting.
Thank you, madam.
Yeah.